my elevator pitch. So I'm playing bridge with somebody and they say, you know, I play competitive bridge. It doesn't seem like it makes sense that that's what I do. It's the only area of life I'm competitive in. Everything else, I really don't care. I mean, I like being a good osteopath, but I'm not really particularly competitive about it. But in bridge, I'm ready to cut everybody's throat. And I've learned to calm that down. I keep the amygdala under control. But I've learned my elevator pitch when I have to explain things to people who have no clue of what osteopathy or cranial osteopathy is. They say, what do you do? I say, I treat traumatic brain injury, not the acute if they need to be in the hospital and they have a bleed. But what most people don't realize is after a trauma, the brain's in the wrong place. And we, through the membranes and the top of the skull, can put the brain back. But otherwise, it's like somebody running a marathon with a fractured ankle. It doesn't work very well. So that seems to really get into people's head. The brain's in the wrong place, we put it back. And if you don't put it back, as Adrian points out, it keeps getting injured and stretched and more traumatized. So that is kind of my elevator pitch. You can try out yours. If you find a better one, I want to know it. But it seems to be sinking into people's minds who don't know much about this. So first, this is me in the Lippincotts 42 years ago. I really feel very grateful. We all stand on the shoulders of giants. And I've been so lucky to have so many people who've been willing to teach me, from Herb to Viola to the Lippincotts. And I say this also with a certain amount of humbleness, because my first cranial course, which was in Philadelphia after my first year of osteopathic school, and all these people, it was mostly other professors. I was just finished my first year. They were feeling this stuff, this cranial stuff. And the day one went, I couldn't feel a thing. Day two went, I couldn't feel a thing. Day three, it was the end of day three. And so I went up to Rebecca Lippincott, who'd come in for the day, and I very humbly, because I really wanted to know cranial. I don't know why. What did I know about it? I mean, I'd met Margaret, and I knew that she was really good at this thing, Margaret Sorrell, but other than that, why the hell I wanted to know it, but I did. So I went up to her very humbly and say, I can't feel anything. And she said, you sit here next to me and you put your hands on my hands. And she transmitted the ability to feel through her hands. I mean, she was amazing. The other thing I found as I worked with her every 2 months, I would drive 2 hours from New York to where they were in Pennsylvania over 4 or 5 years, spending time with her. She had really fierce hands. She was in her late 80s, and her hands were fierce. Of course, she knew exactly what she was doing. And Wales had fierce hands. Viola had fierce hands. Viola came by it very hard because there was a letter from Sutherland to somebody else that I read about how he didn't know if he'd ever manage to get Viola's hands to work the way they should. So it just shows that even if you just keep at this and use your hands and pay attention, the magic that can come. And despite what Adrian talks about how incredibly damaging concussions and brain injury is, but what's amazing is the results we get are phenomenal. The brain has an amazing ability to heal when we pay attention to getting the brain back to the right place, calming the autonomics, and getting the fluid flow, which includes the blood vessels and the CSF. So I always like to thank Dr. Stanley Shirewitz, who protected me when I was in medical school. So part of it is, out there in that big world, most people still don't get it, including most physicians. What's really going on in the head? And they think it's this hard thing and you can throw it around and so what? I mean, football is starting to get people to pay attention. I have a patient in their case history, Gloria, we'll talk about later, probably the end of the day. She was a high school soccer player, and she said I could talk about this, I've given a different name. And the coach, she was a goalie, so she got kicked in the head a number of times. She certainly had her share of concussions. And the coach wanted to make sure that the young women were not frightened of heading the ball. So what does he do? He puts the ball on a baseball pitch and throws it at them full speed. And they have to get used to heading the ball at a high velocity. Is it any surprise that 10 years, I mean, she's 40 years old now, and she's having some pretty serious cognitive problems. Some shrinking of parts of her brain. And so Margaret sent her to me, and because Margaret treats children, I'm sure. And I started treating her, and I'm going to talk at the end of today, kind of go over the case history and which aspects of the various techniques I did. And she has, over 10 treatments, gotten much better. Her mental clarity is better. It appears that when they repeated the brain MRI, it's a special neuroquant, but we're still getting some of her brain tissue has grown again, which is great. That's, to me, part of it is that we're not taking it seriously. We are, but out in the world, how serious some of these injuries are. I put this in because that's what we offer. We offer an amazing sunrise. You know, we have the solution in our hands. What touch can do is we're only beginning to learn the limits. Now, I put this in here. I'm bothered a lot by the, I send people to other osteopathic physicians, and they come back to me and they say, they really didn't touch my head very much, or they didn't do much cranial. And I feel like people are still sort of scared of cranial. I'm going to talk about some of the things to really worry about and some of the things to be more confident about. But I think it's really important we realize that when there's a tremendous force, we match the force. I mean, not exactly, but so part of what I want to do in this course is if you do some basic, good, solid cranial work, you can get 80% change and dramatic change. For the last 15, 20% of the people who are just devoted to it, who are more on the pinnacle, then we get that, up to the pinnacle of our abilities with the cranial. You can take it that much further. And I want people to go from the 80% to be comfortable, to use some firmness in your touch. Now, of course, while you're learning things, it should always be incredibly delicate. I don't want to have to be up all night tomorrow night making sure I fix everybody, or Elliot and I and the other people do. But once you're starting to be more confident, and I think part of what's really important with cranial is a lot of times the brain is kind of upset. The autonomics are screwy. There has to be a real calm in your hands and a real certainty. If you don't have that, back off. And I often say when you're not getting a release, don't try harder, try less hard. And Adrian talked about the problems, this is from our book, Healing Pain and Injury, of treating the injury shock. And we know a lot of the main things. Treating the sacrum. We have to get the sacrum free. Treat the heart. Treat the celiac ganglion. As Adrian talked about, the diaphragm, the sympathetic chain ganglion. But one of the things that actually calms the autonomics more than almost anything else is bringing the brain home, getting the brain in the right place. If the brain's in the wrong place, it has to basically stop moving, because otherwise it's going to shred itself on the sphenoid wing, or it's going to slam itself against the petrous ridge and injure itself. So it stops moving very much. And as soon as you get it back, more toward the middle, it just immediately starts to increase the cranial rhythmic impulse. Nerves don't heal that quickly. Nothing heals that quickly. It's that it's finally free to do its work. So bringing the brain home is so much the essence. And that's what the first 2 hours after we eat is, using the base, which is much denser, the cerebellum, the falx cerebellum, to help reset the brain and the skull. And you can see how it's off kilter in this example. And I also really work on using the falx and the tent to bring the brain home. That's just another there. And the other thing I like to talk about, and everybody who's taken a course with me knows, I find that a lot of times I'm a very impatient person. I like to be in motion and doing and treating and get people fit in and get them out. I don't mind chatting, but I don't like telling people what to do and all that, but I do it. So I use a spiral technique, and we're going to talk about that. And I feel like you can't do it with everything, but a lot of times you can get much faster releases using spiral techniques. And to some extent, that's what FPR is. You're locating it and you're adding a slight twist. Everybody's got to treat the SBS. You know, and I say that I have a protocol for treating brain injury. Now, it's just a proposal. It's not hard and fast. But part of it is when my first 2 years in practice, which was kind of a residency in a way, I worked under Viola to treat the fellows and run the fellowship program at COMP. It's now called Western University. And Viola, of course, was a very hard taskmaster. If you weren't working 90 hours a week, you were a lazy slob. Now, I couldn't quite do that, but I put in my 60 hours. And then at one point, she had a whole system of how to treat children, and she had a whole protocol. And God forbid, I wish I'd written it down, but I didn't. Because back then, I thought I just remember everything. But she has gotten into my mind to try to think in terms of protocols and how to think in a very orderly fashion. And I do think in terms of treating traumatic brain injury, this is really important. And one of the things I say in the protocol is you have got to treat the SBS, maybe not the first visit. If it's a new patient, you know, that's a little invasive, but by the second or the third visit, on almost everybody, you've got to do intraoral techniques. And re-listening to a tape of Howard and Rebecca Lippincott, you know, he said, whenever you're working, you're always focused on the SBS. I don't think that has to always be true, but we have to be brought back to that again and again. Here you can see how the wings of the sphenoid could shred the brain if it's in the wrong place. The other thing I've found in almost every traumatic brain injury, I kept missing some headaches. One or the other of the palatines is always in the wrong place. It's usually the right, and most people's right is more inferior. But recently, yesterday, I just treated somebody who was more inferior on the left. And is that because people are right-handed or the way they come through the birth canal? I don't know. And then Adrian will have a couple techniques on how to release the ethmoid, which is so important. And we also ignore too much the pituitary. 47% of all traumatic brain injury injure the pituitary. And I had a kid who was in a bad car accident who nobody could get rid of her headaches. She was turned watching a video when it got broadsided. Turned out it flared up Lyme and she had these horrendous headaches. And I kept trying to sending her to endocrinologists because I was convinced that her growth hormone was low. And it was low, but nobody would treat it. I finally found one woman in Walnut Creek who was willing to treat low growth hormone, but she got sick or retired, so I've not been able to. Let's see what else here. We're going to talk about the corpus callosum. And one thing I want to talk about for a brief minute is we don't talk quite enough about how where you're hit affects what kind of symptoms you have. Now, I have found the two worst kind of hits are when something smashes the top of the head, even with very few pounds. They come up under a shelf, under the door of the freezer, something drops. I have a patient who a water bottle fell out in an airplane and hit her on the top of the head, you know, out of the cabin. You know, what, pound and a half, 2 pounds? Terribly symptom. Terrible, her life was devastated. She's getting better now. And I think part of that is because when you have a little blow, look, the falx is just going to come and smack into the corpus callosum. Twist it, You really need, and I've just found that that's one of the injuries that's one of the slowest. Of course, what you're doing is you're driving. The weight above the tent is 10 times more than the weight of the cerebellum under the tent. This is effectively 120 grams. This is 1,200 grams. So what you're doing is you're smashing this all down. You're injuring areas here that affect the mood and the sensibility and your ability to function. So you've driven the tent down. So I think that's partly why it is such a bad injury. The other that to me is always the worst is somebody's walking along and they fall backwards and they hit their head on cement. Those people have so many problems. Of course, we can fix them. They've jammed their jugular foramen. You know, they've hurt all this stuff here, and basically they've thrown the brain up here, so they've damaged the orbital prefrontal cortex. I mean, so to me, those are injuries that seem to be even more dramatic. Of course, rotational injuries are terrible, and I do really encourage people to take even a 5-mile change of velocity car accident. There is almost always a brain injury. And time again, I find the physicians miss it, the patients don't get it, and even a lot of osteopaths are not taking that seriously. Now, I do have another patient whose car was totaled, and she seemed to have no cognitive symptoms. So it does occasionally, and she's very little, and she's a woman, and she has all the risk factors, and she never suffered from. So it can be that people get through okay. And then we're the mechanics of fluid, and we want to get the sewage out of the body. And Adrian showed all the different aspects, and we're going to talk more about that. And now this is like old hat, and we don't think that this has much of anything to do with what the flow is, but it's a nice picture. And the dural lymphatics, and then we're going to talk more about the olfactory bulbs and treating the ethmoid, which is a really tricky area that's hard to. Here I wanted to show this nice picture of the optic nerve here. We're so dependent on all the cranial nerves do allow CSF to flow through, and especially the trigeminal is so big, and also the vagus. I mean, that's where I think a lot of the CSF gets through, and we should revere them. Again, a lot of times I said, you know, when you're treating, the tendency is when you're not getting the results you want, you try harder. But I often tell people, you need to go back and sit on the dunes behind the beach and be at a distance and watch the waves. Because the tendency is there's a lot you can do, and I'm pretty firm with using the membranes or moving the bones, but it's always this sense of distance, this sense that I'm respecting what they're asking me to do, what their body's asking me to do. I have my knowledge, and I always have my sense of awe at what amazing job their body has done so far. And that sense of awe does help people heal. When I first started practicing, I always thought, oh, it's going to be much easier to treat children. They have such flexible heads. They are harder to treat in many respects. And it's also important to know that they're much more injured because bodies don't fully myelate until you're 25, which is why it's insane that there's high school football, that anyone heads a ball until they're 25. And like Adrian said, the tissues heal from back to front. Most of the time, corpus callosum and others myelinate from back to front. So just to be aware of that with children, and what I just say to people is this, I have much less of a clear sense of what I'm doing when I treat children. I still get very good results, but it is more direct, just like the Lippincott say, you put things back where they belong, but you also do in acute injury, you do in brain injury. And also, I have in my handout sort of the 7 areas you have to make sure you don't compress too hard. You don't compress at all. Because I am someone who uses quite a bit of firmness, just like the Lippincott's or Ann Whale. I take things and I put them back where they belong. But at the same time, there are certain areas. I never squeeze the spheno-squamous suture. I never squeeze the jugular foramen. I never compress the orbits. I never compress the pituitary. I don't jam between the first cervical and the occipital base. I think I've named them all, but I have a list twice in the handout of the areas, and it used to be, I used to say it to myself all the time for like 10 years. These are the things that you don't compress. Now it's so automatic, I don't worry that my fingers do that. So we'll have our break now, and we'll come back, and I will focus on 2 hours of basically how you bring the brain home.